And we are continuing to focus more on the issues as they relate to Montana. We've dealt with palliative care. We've talked a little bit about aging. We've also talked just very basically about the rural nature of health care. And I think we will probably be plumbing that a little more in this next panel presentation and probably the one after that. This panel, How Telemedicine is Transforming Healthcare, is obviously a very important one, and it's an evolving issue in the state of Montana. It's been around for a good 20 plus years, but there are major events happening with it, and we have a panel of experts to deal with that. Jean Branscum, a member of our planning committee and also the chief executive officer from the Montana Medical Association, will not only introduce the topic, but she will also introduce our next panel. Thank you, Jean.
Well, good morning, everyone, and thank you again for attending the forum this year. We truly appreciate your attention to the healthcare issues that are facing Montana and actually moving forward to identify solutions. One issue that we're going to talk about right now is truly telemedicine, and telemedicine is been forwarded as a way to really extend patient care, provide real-time diagnosis, and even around-the-clock care. It's a booming industry with a global market around $17.8 billion. And so when that kind of cash is involved, there's a lot of industry folks that are jumping into that with the promise of making some cool cash along the way. So with that comes many challenges, and many of those challenges come around how do we protect patients and how do we deliver good quality patient care as individuals are jumping into that marketplace. And the changes in technologies we all know are changing rapidly fast. And so we actually created at the start telemedicine, and we're in favor of that because it was created as a way to really treat patients located in our very remote places. Certainly made sense, particularly in a state like Montana where we have shortages of medical professions across our state. But now it's evolving beyond that, and it's actually being seen as a tool for providing convenient health care. Consumers are asking for 24/7 health care, and they're looking to the internet and new and different technologies to get that health care at that particular time. So recently, even our healthcare insurance companies in the state have signed contracts with telemedicine companies to provide that based on demands from their own area and from their own consumers or their own employers that are paying for those policies. So the advancement and continued development of medical technology and communications is truly having a profound impact in regards to healthcare delivery, but from a physician perspective on the practice of medicine. But it also provides great opportunities to improve the delivery of that healthcare in our state as well. It also presents some unique challenges in regards to regulating the profession and protecting our patients along the way. So today we are pleased to provide to you actually a group of innovators in our state. And when Tanya talked about how long telemedicine's been involved, I would say we've got the, I wouldn't call her the godfather, but when you talk about telemedicine and you say the word, people say Thelma. Where's Thelma? She's been around from the onset of that, and she's going to give us that big bird's eye view of rural telemedicine has come and where it's headed in the state of Montana. So truly an innovator from the ground up. We also have individuals, Dr. Arzubi and Dr. Michael Bush, and they're also going to introduce what's happening in their facilities and across the state in regards to telemedicine and changing how we're delivering care in areas particularly that we find shortage areas, such as in mental health. Again, two great innovators, and I think you'll be excited to hear from them on how we can use telemedicine in great and innovative ways, not only to deliver patient care, but you're also going to hear from Dr. Arzubi of how we could use telemedicine to provide an educational forum to other healthcare providers so they can provide improved healthcare quality, particularly with individuals suffering from mental illness. So with that, I'm going to hand that over to our first speaker, and that will be Thelma.
Thanks, Jean. I don't know if you just said I was old or experienced.
You're just the person we vouch
Today, it used to be we had one term for telemedicine, and that was telemedicine. But today I think you hear and will hear in the industry telehealth, e-health, mobile health, connected care, virtual care, e-care, all these terms that really what we're talking about is method of providing timely access to quality care through technology to improve patient outcomes. And that really is our goal as a telemedicine industry. Interestingly enough, and people always find this very fascinating, Montana has been a leader in telemedicine. And actually, we were doing telemedicine in Montana when telemedicine was not cool. I have to give a shout out to 5 or 6 of our rural hospitals, Francis Mahan Deaconess, Sydney Health Center, Glendive Medical Center, Roosevelt Memorial, Holy Rosary, and the Eastern Montana Mental Health Center. In 1993, those 6 organizations said, we think this is kind of an interesting concept, to use interactive video conferencing to improve access to health care in our region. And to tell you the truth, they were really the pioneers. They said, yeah, gosh, we'll give it a try. We'll give it a shot. And since the early 1990s, our providers and our facilities have embraced the idea of using information technology to improve access to specialty care. And as early as 1994, Montana payers came to the table to cover for telemedicine services. When I think Montana Medicaid and Blue Cross Blue Shield of Montana were really some of the first payers in the country to adopt telemedicine payment policy. And so that really tells you about our state and the organizations within our state and the support for telemedicine as we've moved along. Montana, today, telemedicine is available throughout our state at critical access hospitals, at tertiary centers, mental health centers, community health centers, IHS, tribal health, the VA, even in businesses and into the home. It's quite a difference since 1993 when I used to push what they called a rollabout telemedicine cart that weighed 500 pounds and cost $65,000 to be able to connect to a physician on your iPhone. We have programs such as e-emergency, telestroke, telepsychiatry, telepharmacy, teledermatology, anything you put a tele in front of, pretty much we're doing in Montana. Teleoncology, telecardiology, diabetes education, virtual visits. We also have, in the consumer market, healthcare applications or apps. How many of you have a Fitbit on today? That is a form of telemedicine or telehealth. It's giving you information about your health care, and potentially you can send that information or share that information with your health care provider. It's a very different world. It's a brave new world. So from a perspective of telehealth, I like to define our areas of growth and change in kind of 4 or 5 different areas. Ambulatory care, which I consider our outpatient care, where we're connecting our physicians to patients. In that specialty service areas I talked about, cardiology, oncology, diabetes education, the things that normally you would travel to for care to a local facility. The other area that we're seeing significant growth in is acute care telemedicine, which is real-time access to specialty care that impacts the outcome of an acute patient, assisting maybe a local care provider or facility the safe and efficacious transfer of a patient to a higher level of care, or the retention of that patient at that facility because they don't need to be transported. Continuity of care, managing ongoing chronic disease, using remote monitoring technology, virtual visits into the home. And then the probably the last area, and at times has been the most controversial because I think it's the newest. And I think about the controversy we had in 1993 when I asked doctors if they would see patients over TV. The reaction was not the greatest in the world at times, but it's the area of direct-to-consumer, in which we are actually going directly to the consumer to provide care for minor health issues. The other area which Dr. Arzubi is going to talk about a little bit is ECHO, and I think the promise of ECHO for a significant impact on the quality of care that we provide throughout the state is critically important. Jean asked me to talk a little bit about barriers, and if I ever thought that there was a barrier in front of me around telehealth, I probably would have quit 26 years or 23 years ago. I always think of barriers as an opportunity to create a more telemedicine-friendly environment. Isn't that a good way to think about it? But today, I think when we think about barriers to telemedicine, it's because we're working in a system that was designed and regulated for in-person care. It's a system that was not designed to think about the fact that we can potentially receive care remotely. And that for telemedicine to really realize its value and potential, we must remove these artificial barriers that were developed for an environment that is now changing significantly. Just real quickly, Thanksgiving Day, I was at a friend's house, and their iPhone rang. And next thing I hear is kids screaming in the background. And what it was is our friends' grandchildren had called them on Thanksgiving Day to say hello, wish them happy Thanksgiving, etc. That is the environment that we live in today. We have the ability to connect to individuals in a way that we never have had before, and it's mainstream. And the barriers that we've put in front of ourselves around the implementation of telemedicine are the barriers that suggest that you have to drive to see your physician, or you have to go somewhere to see your physician or your healthcare provider. People don't have to necessarily travel anymore. So reimbursement models, we need to develop reimbursement models that incent providers to use telemedicine and support the expense of the provision of telemedicine for the care at the rural and frontier sites. One of the many challenges we have in Montana is the expense of the technology at the rural site. The other thing we must do is streamline licensing, credentialing, and privileging processes to make it more convenient for providers to license, credential, and privilege, but I'm going to wave Jean's flag always, but to ensure patient safety. And that is a hard process to put in place. But I think Montana has been willing to step up to the plate in that area. Montana was one of the first members of the Medical Compact, Licensure Compact. That's, I think, a good step forward for us. Also in Montana, 2 years ago, we passed an insurance parity law, which requires private insurers to cover telemedicine services. I'm going to mention the federal level a little bit because our federal government has been a little slower to react and remove barriers for the use of telemedicine. And it creates some interesting challenges for us in Montana. But we will continue to work at the federal level to make those changes. The other barrier I want to talk about, which I think probably is the more difficult barrier, is the human resource barrier and the availability of actually having providers to be able to provide the service to our patients and clients. We know that there's a critical issue in Montana around mental health services, and utilization of telemedicine to provide mental health services is critically important to the state. And one of the things that I think we're able to do with telemedicine is you go to where the resources are. So potentially we can use outside providers, out-of-state providers to bring services into our state. Critically important. I want to leave you with one last thought. Telemedicine is only a tool. And I think as we look at the challenges that we faced in healthcare, I always like to step back and say, what is the issue? What's the problem? what is the best solution, and can telemedicine technology and services be a part of that solution? And I think if we think of innovation in healthcare, always to think of all of our options is critically important for this state. Thank you.
I like to stand up. I like standing. No, I use my hands. I'm going to hit people if I. So again, my name is Dr. Eric Arzubi. I'm chair of the psychiatry department at the Billings Clinic. I'm also president-elect of the Big Sky Regional Council on Child and Adolescent Psychiatry, and I'm on the Governor's Council for Healthcare Innovation. I think, given given what I do for a living and thinking about the mental health challenges we're facing, I think it really behooves us to think really outside the box, and I think technology affords us a lot of possibilities that otherwise wouldn't be there. So the three things that are important to keep in mind when we think about technology and the use and how to implement that in medicine is, I think about it as follows. Number one, it can help us lower transaction costs at times, right? So we can avoid travel if it's not possible. Also shorten the time to see patients not having to travel, wait, come to the clinic, and so forth. So we lower transaction costs. The other thing is we're redistributing clinical capacity, right? So, for example, we're lucky enough to have 12 psychiatrists and I think 4 nurse practitioners in our department, but it's all in Billings. So how do I get that clinical capacity outside of Billings and outside of Yellowstone County so that people who need to access it can do that? And technology is one of those things that can afford that possibility. And then because of that, it helps us increase access to high-quality care, right? And that's in all corners of Montana. So just want to give you a couple examples of some of the things we've been up to, and then later we can take questions when we're sort of as a panel. But just a couple of sort of more straightforward examples. One is we had a psychiatrist reach out to us a couple of years ago, or about a year and a half ago, saying that she was going to be moving to Montana, but didn't know if there was any work available. And I said, yeah, I'm going to find you something. And now it turns out her husband now is a dentist in Bozeman. They wanted to go to Bozeman, which is fine, but we didn't have any capacity there at the time. And so I was lucky enough to, Billings Clinic is, if I can make the case that there's a need, there's the flexibility and leadership to be able to make some adjustments. And sure enough, we were able to get this psychiatrist to join us. So she's working out of Livingston Healthcare. She's part of our department, but she's working out of Livingston Healthcare, seeing patients in person 50% of the time. And the other 50% of the time, she's working seeing patients in Glendive using telepsychiatry. So essentially, we've created a half an FTE psychiatrist in Glendive because Glendive lost their only psychiatrist about a year ago. So Glendive had an inpatient psychiatric unit at some point, had a psychiatrist seeing outpatients, and then lost that psychiatrist about a year ago. So again, we had sort of this clinical capacity that appeared magically, which I wish it happened more often, but it appeared, and we were able to kind of redistribute that clinical capacity by keeping some of it in Livingston and redistributing half of that FTE into Glendive using telepsychiatry. Another thing that's happened is, like Thelma mentioned, is bringing in out-of-state expertise. I mean, we have a lot of brilliant people in Montana, but there's still a lot of expertise that we need to kind of sort of import when needed. So we worked with Fort Peck on a HRSA grant. Fort Peck got a $1.2 million grant to try to provide, do two things. One is make their telemedicine infrastructure more robust, and number two, work then on providing behavioral health services into their school-based health centers. Fort Peck, it turns out, is pretty progressive when it comes to thinking about systems of care. They have 4 school-based health centers, and I think we're one of the pioneers in Montana in rolling out school-based health centers. So now, as you can imagine, Fort Peck has a hard time trying to recruit people and to practice there in person. So we're going to be working with them to increase to make their telemedicine infrastructure more robust, and then try to provide some behavioral health services into the school-based health centers. And I trained at the Yale Child Study Center where I got my child psychiatry fellowship, and we're going to be working on getting child psychiatry fellows to help with some of that, so from New Haven into Fort Peck. Again, we're still a ways away, but that's one of the things we're trying to do because we don't have enough child psychiatrists to be able to do that into Fort Peck, so let's import that capacity. Next is Insight Telepsychiatry. Insight Telepsychiatry is a national provider of telepsychiatry services. They're based out of New Jersey, but it doesn't make them bad people. I'm kidding. So now the business. It's interesting. New Jersey is where this business got started. It actually used to be really a mental health center of sorts. They started providing some telepsychiatry into emergency rooms locally because this shortage, while it's most acute probably in Montana, is pretty significant everywhere. So they were trying to provide telepsychiatry services into local ERs, and they started doing this, I think, probably about 15 years ago. And so what they did, they created a business out of this, and now, in addition to having their local mental health resources and a lot of it is child psychiatry, they've created a separate business now where they provide telepsychiatry services around the country. I think they have 200 MDs and like 75 nurse practitioners. And so these psychiatric providers are placed all over the country. And so what we started doing about 3 months ago is covering our emergency room overnight. Before we started using this service, after 10 p.m., our patients in the emergency room would see someone for an in-person evaluation, but that person would be a licensed clinical social worker to do an initial psychosocial evaluation and a risk assessment, and then over the phone would have a conversation with a psychiatrist. Now what we're doing is we're able to do that in-person assessment with a social worker and an in-person assessment using a psychiatric NP. So that's now the quality of care is going up because now a provider is doing a face-to-face visit with every single person that comes into the emergency room between the hours of 10 p.m. and 8 a.m., and that wasn't happening before. The other thing that does is it frees up our docs locally to then see patients the next day because the folks who were on call weren't able to stay awake the entire 36 hours on a consistent basis and do the best job that we can. And so now we're able to improve quality of life for the providers that are here, provide better access to care in the emergency room, and these guys get to make some money, I guess. So besides sort of doing in-person visits, they're thinking about technology and providing medical care. I think we got to think again. I keep talking about thinking outside the box and doing things that aren't really common. So one of the things that happened is back in August, I believe, the University of Vermont published a paper on an app that they created. They created an app to do suicide risk assessments on an iPad, and essentially what they did was they would go into the emergency rooms, give this iPad to patients, and they would fill out these questions. Now the questions are based on algorithms, so what they try to do is mimic the logic that the psychiatrist would use to provide a risk assessment in the emergency room, and then stratify by low, medium, or high risk. And so again, this is sort of in the early phases of development, but one of the things we're trying to do is work with the University of Vermont to see if we can, number one, see if it makes sense for a setting like ours. Number two, does it make sense for this sort of context and culture? And then number three, if it does, imagine if we had the ability to provide high quality suicide risk assessments across the state using an app that again is based on very sophisticated algorithms to determine risk. But again, another way that imagine that if there were remote places who didn't have a psychiatrist available with experience assessing for suicide risk, now can do this with something that's been well studied and published in peer-reviewed journals. So Project, and before I jump into Project Echo, there are a couple other things, again, thinking about uncommon ways that technology can help enhance our quality of care. There's a TED Talk that I saw on a gentleman, he's a neuroscientist who studies language and syntax and pragmatics of language. And what they were able to find out is when people who are at risk, let me switch this around, people who develop schizophrenia, one of the early impairments they have is in cognition and language. And so what they found was by analyzing the language, not only written but also spoken language, if you take 100 people, or I forget how many people they actually worked with, but they took a group of people who were at risk for developing schizophrenia based on family history and some early factors. They then analyzed the language in terms of pragmatic syntax, how they were talking, the written language, and were able to predict to almost 100% accuracy who actually developed schizophrenia. Okay, so again, another example of using technology to enhance our ability to diagnose and assess. And then another interesting model in terms of using technology and mental health is there's something called the implicit association test. And it's an old test in psychology where if we were to flash on the screen a bunch of words, the words might be would be the names of colors, green, blue, red. But what I would ask you to do is name the color in which that ink is written, right? So it might be the word green, but in the color red. And I want you to start reading it really quickly. And it's very difficult to do because automatically you want to read the word instead of say the name of the color. So it turns out by measuring how long that takes, you can try to understand how well people are able to kind of suppress certain impulses. I'm not good at that, but if you look at the implicit association test, and they study this with words, for example, such as suicide, death, hopelessness, trapped, and words like that. So what they did is they studied words that are associated with suicide, then neutral words, and then some other words that have nothing to do with sort of emotions. By looking at the timing, at the amount of time it took people to respond to these things, and you're looking at milliseconds here, they were able to predict who was, and again, the science isn't perfect yet, but they were able to predict with some pretty good probability who was likely to harm themselves or commit suicide or attempt suicide by seeing how long some people are really stuck on certain words. So again, I invite you to think about, when you think about e-health and technologies around health, it goes way beyond sort of just having a video camera and people talking to each other. And then lastly, I'm going to talk about Project ECHO. Project ECHO stands for Extension for Community Healthcare Outcomes. Essentially, it's a telementoring platform. It's a bunch of webcams. That's it. But this thing was started 13 years ago in New Mexico, and some of you have heard me talk about this before, but just to give you the quick recap, 13 years ago, there was a hepatologist who was treating patients in New Mexico who are struggling with hepatitis C. Again, similar geographic challenges that we have here in Montana. They were waiting months at a time to get access to care and to see the specialist. And several people were dying while on the wait list. So Dr. Aurora got really frustrated with this and said, let's create a network where we have a hub and spoke model. And the model he eventually landed on was at the hub, which was in Albuquerque, New Mexico, he had a hepatologist, a psychiatrist, and a pharmacist, along with a social worker, as sort of the quote-unquote expert hub. And then the spokes were primary care sites all around the state. And they met every single week for 2 hours. For the first 20 minutes, 25 minutes, they conducted didactics. So the hub would present a sort of a mini lecture on best practices in the treatment of hepatitis C and mental health issues associated with hepatitis C, along with new medications to treat hepatitis C. And then in the following 90 minutes, the spoke sites all around the rural New Mexico would present cases, difficult cases around hepatitis C and comorbid conditions, and the network would discuss these cases. So while there is a sort of a hub of experts, the idea is that the entire network contributes, right? Many people have heard about the concept of the wisdom of crowds. We have a lot of brilliant people in rural Montana who have a lot of knowledge to share. So while we might have, let's say, so at Billings Clinic, we created this around mental health. And so, yes, we have a hub of sort of quote-unquote experts, but our job is really to create a safe environment to have very robust clinical discussions, right? If I have somebody in rural Montana asking a question where some people might think, wow, that's a silly question, as soon as something like that comes out, people are going to feel unsafe to talk about their insecurity around treating certain issues, ask questions that they might feel insecure about asking. So we got to create a very safe space to have very robust clinical conversations and allow the entire network to teach itself and enhance the quality of care. So there was a New England Journal of Medicine article that was published around Project ECHO and the treatment of hepatitis C, and they found that in rural sites, the quality of care around hepatitis C was as good as it was in Albuquerque at the academic center. And if you think about this, right, you are having now patients stay in their own communities, stay connected to their primary care physicians, not having to travel to Albuquerque, and the physicians at these primary care sites were now empowered with best practices, sort of cutting-edge research, best practices that they were able to discuss in these weekly meetings in Project ECHO. So what we've done is in March, we launched our first Project ECHO clinic, and that was to support corrections and corrections-related facilities around mental health and addictions. Right now we work with several pre-release centers in Billings and a couple around the state. A couple of prisons dial in, and then Department of Corrections in Helena dials in. And what we do is exactly this. We meet for an hour and a half, 25 minutes. We do didactics on mental health issues. And then for the following hour, we discuss cases that are presented to us by the pre-release centers or the prison. And what's nice is with the collaboration with corrections, they're able to help us understand what are some systems barriers that are getting in the way of providing care to some of these folks in the system. As you might know, about 2/3 of people in the corrections system have a diagnosable mental illness. Our corrections system is the largest mental health system of care. So if we don't take care of this, we're going to have problems, right? We're going to have problems with recidivism, with cost, and these untreated mental illness when they come back into the community is going to cause a lot of sort of costs and also increase the probability that they get back into the corrections system. So doing something like this, I think, makes a ton of sense, and seeing the quality of the discussions improve over time has been really rewarding. And the other great partner in this has been the Rimrock Foundation. So they essentially what we've done, we've created sort of this multidisciplinary hub where we have a psychiatrist, a psychiatric pharmacist, and Malcolm Horn, who is the lead sort of clinician educator at Rimrock, who participates in this, and we provide and facilitate these discussions. So next, we'll be doing this with integrated behavioral health beginning in January, February. Project Echo, the Project Echo around this about integrating behavioral health into primary care. Actually, our hub is the first in the world to be funded in a private-public partnership. Blue Cross Blue Shield, Pacific Source, and Medicaid have gotten together to help fund this. So our next goal is to facilitate and disseminate best practices when it comes to integrating behavioral health into primary care. And then after that, we're working with the University of New Mexico on a HRSA grant to, again, disseminate best practices when it comes to treating opioid dependency. So really what this has become is almost like you're creating these channels, these virtual channels to distribute best practices and facilitate two-way conversation about these clinical cases and improve the quality of conversations around the state. And I'm learning just as much as the folks, I hope, as the folks in the rural settings around some of the barriers to care and actually treatment. Yeah, I'll shut up now because I'll go on forever. So again, the main points here for me are, number one is, right, technology can help us lower transaction costs. Number two, we're redistributing and decentralizing clinical capacity. And number three, increasing access to high quality care. And I'll take questions afterwards. Thank you.
Well, I'm very glad that Dr. Arzubi came up to the podium because I was sitting there with half the room blocked out by the flag and the speaker and thinking, I'm going to go up to the podium. But anyway, so I'm Mike Bush. I'm the Chief Medical Officer at St. Vincent Healthcare. I've been here in Billings for 26 years, and my background is emergency medicine. But I was going to talk a little bit differently than what we've add a little bit more to what Thelma talked, but what we're actually doing with telemedicine today and what's actually happening. And so when I was the medical director in the emergency department at St. Vincent early in the 2000s, and I don't remember exactly what year, we became one of the early sending sites for telemedicine in conjunction with the University of Utah Burn Center and Dr. Jeffrey Saffel. And so I've had that experience of being on the end where I had the patient with the expert on the other end of the telemedicine connection. And that's been going on for close to 15 years at this point and has been highly successful. And that has helped us in several different ways from the standpoint that we have somebody who's going to be taking this patient over from us once we fly them there. They're actually getting to assess the patient, participate in their care, and make recommendations to us about what they think best care would be prior to starting that kind of care when they get to their final destination in the burn center in Salt Lake. So I think that's been very helpful. On the other hand, there also have been patients that are sort of in that gray zone. Do we need to send them to Salt Lake? Do we need to inconvenience the family? Or can we keep the patient in Billings under the care of our surgeons and do some of the more simple things that can be done for those patients? And we indeed have been able to do that and keep some patients local. And I think that's one of the real benefits with telemedicine. Another area that I think is really important with telemedicine is I think it's hard to reproduce, and maybe with the younger generations where they're getting more and more used to this, but it's hard to reproduce that personal interaction, that face-to-face interaction when you're meeting a patient for the first time. And our oncologists now actually have a very well-established program, and they're seeing a lot of patients virtually, but most of them are follow-up patients. So a lot of patients in eastern Montana, as Dr. Arzubi was talking about, the travel time, the time away from work, those kind of things. If they can be, seeing follow-up visits with our physicians from they're close to their home, that's really an advantage. And I'll talk about one barrier real quick because Thelma was talking about barriers. But right now, most telemedicine in that kind of environment has to occur healthcare facility to healthcare facility. It isn't set up to occur home to healthcare facility. So we're getting ready to do that with one respiratory therapy situation that I won't go into, where we're actually going to be going into the patient's home. But again, so that's a challenge that as we look at further legislation and those kind of things will come along. Another thing that we actually have going today, and we're almost a full year into it, is what we call Doctors. It's a company called Doctors on Demand. And SCL Health, our system, has partnered with Doctors on Demand to roll out through Virtual Health primary care practices. So you can go out on your iPhone or your Android or whatever, download the Doctors on Demand app, and for $40, you can click their button. Within 5 minutes, you're talking to a physician on your phone with video capability, so they're actually looking at things. Now, what they're actually treating in those situations are list of about 10 different diagnoses: upper respiratory infections, conjunctivitis, pink eye, ear infections, different rashes, some of those kind of things. So it's not, really complicated things, but it's things that can be done. Also, when we were at the MMA meeting in September, I understand that Pacific Source and Blue Cross are bringing forward their, again, associations with other national companies that'll be rolling out, I think, early in 2017. So more will be happening that way. I would tell you that as we looked into doing this, I think it was 2015, and I had this in some slides, but I'm not going to bring them up, but about 1.5 million virtual health visits across the country in 2015. The projection is by 2020 there will be 600 million virtual health visits. And again, as you see what's happening with what people are doing, think about your shopping. I mean, some of those things, people spend a lot of time on the internet, and healthcare is one of the things that is going to be coming from that standpoint. The convenience for the customer is certainly there for some of these things where they don't have to drive, don't have to wait, etc. But I would also talk about it from the physician standpoint for just a minute. I actually had a chance to meet an emergency physician a couple of years ago who works for one of these companies, and he lives in Mexico. He has a private free clinic. It's not private, but it's a free clinic in Mexico that he staffs, and he works 4 hours a day doing telemedicine virtual health visits for primary care, and that's how he funds his work in the clinic. And so there are opportunities for doctors that have those kind of inclinations that want to do that. There also are people, if they're young physicians that are trying to raise a family, they can be get their family off, drop them off at school, drive back home, sit down at their computer, maybe put their coat and tie on, whatever, with their pajama bottoms on, but be in front of the computer screen and commit to doing 2 hours or 4 hours or whatever, and then pick up kids or wherever they're at. But it's a convenient thing, or get the kids to bed at night, and I'm going to see patients from 10 o'clock at 10 p.m. till 2 a.m. And so, again, as you look at the younger generations of physicians, there's a lot of people that actually find this kind of healthcare attractive. And so the data we have back is more on the satisfaction side, some data on the quality side, but the patient satisfaction with the interactions they've had have been pretty high. We first rolled this out, before we rolled it out to the public, we rolled it out to our associates and let them try it for $10 a visit. And what we heard back to a great extent was, I was on vacation in Phoenix and my child got a rash and I just dialed him up and, got it taken care of without having to do anything else. And so there were a lot of different feedback, but I think more to come in that area. But I do think that is a trend that's not just a trend. I think it's really here to stay, and we're on the cusp of that. So another area I wanted to talk about is tele-emergency medicine. And so Thelma had mentioned e-emergency. E-emergency is a product that had been rolled out or is out there from Avera Healthcare. And Avera is a system based out of the Dakotas, very aggressive in this area, and this was funded by the Helmsley Foundation. And Leona Helmsley, her foundation that she left, really is focused their charitable contributions in the Great Plains, Northern Rockies area, because they see our area as being one that is, for want of a better term, philanthropically deprived. And so they have committed to putting money in here, and there's been a lot of money that was put into this system. And in reality, I think, and I'll tell you, my opinion on this is now starting to change a little bit, but I really thought what they're doing with e-emergency was the right way to do this. And they actually have emergency physicians that go to what they call the black box. They've got all their monitors, all their cameras all set up there. They've got an emergency nurse there with them. And they're able to provide virtual care to these small rural critical access hospitals and provide telemedicine support to the PA or whoever's out there providing the care. And that is the Cadillac version of what we're going to do in providing telemedicine in those kind of settings. And I really thought that was the way to do it. However, as I've seen it roll out now over 3 years, and the grant funding is now starting to roll away for this, and now it's having to stand on its own, some of the contracts that are coming out are proving to be pretty expensive, more expensive than a lot of these small communities feel they can afford. And that's really the challenge. And initially, when we started into our grant for our tele-emergency program at St. Vincent's, I was not a fan. I thought, we really should be doing what Avera is doing. But then as I started to see the cost and some of that roll out, and realized that what we're really trying to do is roll it into the normal work practice of an emergency physician. So when I still work in the emergency department a little bit, and when I'm working in the emergency department, I'm usually working with 2 or 3 other emergency physicians. Our workstations and have a tracking board is the first thing that we see, and that's how we manage our patients, follow our patients' flow through the emergency department, etc. And we have about 17 facilities that have now signed on to us. And to be honest, this hasn't really taken off yet. And so I'm not convinced which way this is going to go, but it makes a lot of sense to me that this should work. But if there's a PA or even a physician in some of these communities that would like to have the expertise of an emergency physician to participate, we essentially have in their facility put in an iPad on a pole is the joking way to say it, but it's not the really technical equipment that we started out with in telemedicine. Literally, it's an iPad. We're using a app called Vidyo, V-I-D-Y-O, that is a HIPAA-compliant version of Skype. It's really, but the thing is, it is HIPAA compliant, so it can't really be broken into and that kind of thing. And as that patient comes on my tracking board, I'm working in the emergency department here in Billings, I can just step out of our room where we do a lot of our work into a room right next door. There's a telemedicine monitor, some screens, that kind of thing. I can actually access the patient's record. There's a patient record in our record that I get to actually do my work in. And the local facility gets to bill for their emergency care. I get to bill for my emergency care. And if the patient needs to come to Billings, we arrange the transfer. If the patient can stay there, they stay, and the local facility provides the care. So I think there's more to come on that. I think there's a lot of questions. I think Thelma and people in her role are going to be very key in what happens with these things going forward. The final thing I would say is Dr. Arzubi mentioned Insight, and we have executed a contract at St. Vincent's with Insight. We certainly don't do the volume of psychiatric and mental illness that they do, but we do have needs to provide mental health and psychiatric consultations in the hospital. And we're in the process of operationalizing our contract with them, and as Lyle knows, that takes a while sometimes, and have to recruit physicians and credential them and put your processes together. But sometime this spring, ideally, we'll be having psychiatrists seeing patients by telemedicine in our facility. So anyway, so that was all I have, and be open to questions.
Well, thank all of you. We do have some time for questions. We certainly have a panel here again of true leaders. I thank you for that. You're certainly blazing the trail. I just want to call out Dr. Michael Bush, too. When you think about folks that are thinking out of the box, he talks about his emergency care background, and just want to recognize probably in the 80s, he actually was one of the ones that developed our trauma care system in Montana, and saving lives every day because of that kind of system we have in place. So thinking out of the box isn't new to any of these folks. And here to take questions. Any questions out there?
To anyone on the panel, or maybe others who are in the audience, I'm wondering, since the passage of that legislation around insurance parity in telehealth, have any of the payers aggregated their information, or is there any sense that did stimulate new uses, and in what kind of settings? It's a question.
Christiane, you always ask the tough questions.
Thank you, Christiane.
This is anecdotal, this is experiential, not necessarily based in data, but our experience in Montana around private insurers is that we don't feel that there's a barrier there. So that what I've seen, particularly in the last 5 years and specifically in the last 2 years, and it's hard to kind of say what the reason for this is, we're seeing exponential growth in the use of telemedicine in all areas, and having reimbursement makes a difference. We still have barriers on the federal level, and so the big picture is it's still reimbursement still is a challenge, but from a state perspective, I think we are in good shape around telemedicine reimbursement. Our Medicaid reimbursement policy is great. Our private insurers are great. The interesting thing about the parity law, though, it does not require self-insured policies that are managed by payers to reimburse for telemedicine. So if you are self-insured, you may choose to not reimburse for telemedicine. So that's been kind of an interesting challenge. For the most part, you can request that coverage. That can be a part of your plan, but it's not mandated by law.
Christiane, I would add just one thing. I would echo what she said about the barrier being the federal government, but the fact that our state is more geriatric than a lot of states, more Medicare, is really part of the issue. And then the other thing is what I talked about earlier, which is right now to do the billing and to do those things, it has to be healthcare facility to healthcare facility, and that is a real barrier too.
Other questions?
Hi, I'm Deborah Franson. I'm with Senator Tester's office, and this is more of a point of information. Senator Tester's bipartisan bill expanding capacity for health outcomes, ECHO, passed the Senate yesterday. 97-0, which is, in the United States Senate is pretty unusual. And the bill is a successful telehealth initiative that's currently being used in clinics across Montana and across the country to improve specialty care in rural health care facilities. And this bill, Project ECHO, will require the United States Department of Health and Human Services to submit a report to Congress that identifies how current telehealth projects are funded and recommends how to integrate these existing models into updated funding streams and grant proposals. So the ECHO law must now be taken up by the House of Representatives. So if you are interested in seeing this bill become law, please contact Congressman Zinke's office and encourage him to support the ECHO project. So thank you very much.
Thank you. We appreciate the Senator's good work on that. Question over here.
Mental Health America, Montana.
Okay. Is that hello? Okay. So the question is, so who would be the audience? There would be private practitioners?
Private practitioners who are using Insight as their platform doing telehealth in Montana. But also we recognize that part of that is we'd like to have a venue for those practitioners to have consultation with psychiatry.
So so what's nice about Project ECHO, look, the only barrier to that is money, right? So there are webcams everywhere. We can get access to a platform to be able to communicate. So ECHO has been used in, I think, like almost 40 different topics and specialties around the world in 100 different hubs. So you can build anything onto the ECHO platform. So if there's an appetite and there's funding for it, you can build it. So if, for example, so if you're looking at you want to look at psychiatric consultation for these folks and presenting cases, there's no reason if there's the funding that could be done.
So, I guess this is on. The other thing I think that's important to know that anybody can join any ECHO anywhere in the country.
Yes.
Correct.
Yes, there are very few exceptions to that. So, for example, if you want to join in and listen in on Project ECHO, either ours when we launch, the other ones, or the ones in New Mexico, for example, I think there are five hubs, and what's nice about this, there are 5 hubs that focus on mental health around the country right now. University of Washington, Oregon Health Sciences, University of New Mexico, University of Rochester, and we communicate regularly to make sure that we're all sharing best practices. Because as you probably well know, in mental health, sometimes practitioners kind of do their own thing depending where they are, and we don't want that to happen here. So what we're trying to do is we're trying to stay on top of best practices nationally and make sure there's a real standard of care. So anyway, I think using this for mental health, I think is growing, and you can access other ECHO clinics as needed. But University of New Mexico, for example, is always happy to let people listen in.
Well, I want to thank the panel members. We are appreciative of the out-of-the-box thinking that happens within your systems, and appreciate the systems you work for, because they are investing in this kind of technology with the patient care in mind. When we talked about the panel being informed, we talked about, let's talk about the benefits and let's also talk about the challenges. So I was kind of keeping a tally here of what the speakers were talking about. And certainly the benefits of telemedicine far outweigh the challenges, and the challenges are easily overcome if we can work together on those. Benefits that you heard from our speakers range from, this isn't new to Montana. We actually were out there on the cutting edge, and we led the nation in telemedicine. We know the importance of providing care through telemedicine and technology to our rural areas. It can lower transaction costs. It can redistribute the capacity. There's access possible to high-quality care utilizing telemedicine. We have reimbursement laws in Montana that's parity. We can do a little bit more work on that as we change settings into the home setting, but we're in a good footing right there. We also have ability to provide care in far new settings that can be highly successful, such as school-based settings. It also helps to ease the workforce shortage for physicians by bringing in and supporting our family medicine physicians in the areas that they work. And we can support those family medicine physicians in far and new and different ways, such as in the mental health arena and also in dealing with individuals who are suffering from chronic pain. So great list of benefits. So what are the challenges we're facing that we need help on and some more policy discussions? We do need to think about the new technologies coming and the settings that are emerging. We can provide care right into the homes of individuals. So is reimbursement there and able to provide payment for those settings? We need to look at that. We also need to build systems that support telemedicine, just like we have systems that support traditional medicine with in-person settings. We need to provide for patient protections. We need to make sure that when we establish that first patient-doctor relationship, that there is an eyeball-to-eyeball reaction there, that we see folks through a video, audio connection, or an in-person connection, and let the care happen beyond that as is appropriate for that particular setting. We need to look at credentialing. Can we standardize credentialing? It's a pretty painful process on credentialing physicians so that they can work across systems and within different insurance companies. Licensing is another place to look at that might be a barrier. We talked about that licensing is getting easier with the Medical License Compact, but we also heard from the Board of Medical Examiners that if you are a physician and you have a patient that was in Florida or Arizona on vacation, you need to be licensed in those states. And so when we talk about telemedicine and staying connected to our patient, we need to be cautious about when we are going into those other states, how we can take care of our patients wherever they may wander and be at, and provide that easy, convenient piece. And we can't lose sight, again, of our recruitment of physicians in our state of Montana. Even though we are using telemedicine, there is no replacement for having a physician right in your community. The economic returns to our local communities, I believe, is $1.25 million for that local town. We've got to fight to keep physicians on the ground, boots on the ground in all our cities and towns across Montana, and with that comes the support of our medical school in Montana, WWAMI, and also our residency programs. So working all together, we can keep a vibrant community of healthcare across Montana, and with out-of-box thinkers like the folks here on the panel and all of you helping us do that, we can get that job done. Thank you very much.